A very good morning to all of you. I welcome all of you to the master class in Oculoplasty. In this master class, primarily we are dealing with important topics which we see and practice in Oculoplasty on day-to-day basis. We have got a very good team of speakers. First, I invite Dr. Anish Sridhar to speak about orbital approaches. She is a senior consultant in Little Flower Hospital, Angamali. Over to Dr. Ani.
Okay, Marian has asked me to speak on how do you approach an orbital mass or orbital tumor. So, first of all, when should you do an orbitotomy? Whenever there is a mass, you have to biopsy. Okay, whenever there is a mass lesion, you have to biopsy. Are there any PGs here? 2 or 3 are there? No? You are PGs or? So we found that Little Flower, when we did the audited them, we found that lymphoid and inflammatory tumors were the most common. So first you have to determine if the mass, where the position of the mass, is it retrobulbar, peribulbar? Should I do an incision biopsy or an excision biopsy? Incision biopsy is when you just take out a piece of the tumor for biopsy, and excision is when you remove the mass in toto. Which is the best route to go in, and which is the best incision for cosmetic reasons. So you should always follow the lines of tension which are shown here, so to minimize scarring, because face is a very important aspect of a person's personality. So in the anterior orbit, we mostly go through the anterior superior orbit to the superior lid crease incision, and a subciliary incision for the inferior orbit. And lateral orbit, we go mostly through the upper lid crease incision, which is extended along the laugh line, which is the incision F. The medial orbit, again, we now use the superior lid crease for the medial orbit. But if you want to go through the conjunctiva, a medial plical incision, or if the mass is very large, an upper lid splitting incision can be used. That is the incision J. So the inferior orbit will first see the conjunctival route is through the fornix. The subciliary route, which gives minimal scarring, it's very good exposure also. And the inferior orbital margin route will give a scar at the inferior orbital margin that's not used by oculoplastic surgeons now. So this is a peripheral anterior hemangioma in the inferior orbit. The CT scan is not that good. So here I am sitting at the head end of the patient and operating through the video is taken through operating microscope. I have inverted all the diagrams so that the lower lid is coming, as I see it, the lower lid is coming at the top of the incision, top of the diagram. So here I have gone through the conjunctival route because it's a small mass, and through the cryoprobe you can extract it and then suture the conjunctiva. So this is an inferior lateral mass which I have approached through the conjunctiva again, and it's a huge mass extending quite posteriorly in the orbit. So when you go laterally, you have to think about encountering the inferior oblique muscle. And here I found that the inferior oblique muscle was draping over the mass. So after consulting with Dr. Meena, who was squint surgeon, who was in the next room, we decided to sacrifice the muscle. So when you are cutting the muscle, you always have to put sutures and cautery. I have not used a cautery here, but you have to cauterize the edges of the cut muscle, otherwise it can bleed post-op. So that mass was removed and the conjunctiva was sutured. This was a mass with a huge mass of long-standing with microsis, macrosis and fibrosis, and I thought of debulking the mass, and you can even see calcification in the mass. So it was a lymphangioma. So tagging the medial rectus muscle, and then you can see there was bleeding from the mass. So I aspirated some and injected bleomycin injection for fibrosing the mass, and the fibrous part was cut away, it was debulked, and the conjunctiva was sutured. This was again a huge mass filling the inferior orbit. It was extending to the medial orbit too and pushing the eye literally out. So here the lower lid swinging approach is very useful, and you just have to detach the lower lid from the lateral orbital margin, and you can have access to the whole of the lower orbit. This is a huge mass, and I'm not showing the whole video. The lower lid will then have to be reattached to the lateral orbital margin, just like you do a lateral tarsal sling. So this is a mass which is encapsulated. It's a fibrous histiocytoma. It is now coming under the classification of solitary fibrous tumor. So this was a mass which was felt to be very hard. And how do you know if a mass is anterior to the septum or posterior to the septum? Ask the patient to look up, tense the septum, and if it's becoming more prominent, it is anterior to the septum. This was straddling the septum. So this was taken out to the subciliary route with good cosmetic effect. This was an inferior infiltrating mass, infiltrating the maxillary sinus, and I thought it would be a carcinoma, but it turned out to be a fungal gram. In such cases, do not aim at removing the whole mass. You just have to do an incision biopsy, and this patient may require radiation and such things. So always go through the conjunctiva so that the skin is protected later. Here I am going directly to the periorbita, elevating the periorbita and then taking out a small piece of the mass for incision biopsy. Infiltrating mass, you need not aim to remove the whole thing. This was a superior molding mass. So molding masses, what is it? Molding masses. PG is only one seen now. So this is a lymphoma. So here too, it molds around the globe. You need not aim to take out the whole mass, just a small piece. So here I am going through the superior conjunctivas because the patient may require radiation later. So this video is kept to show that whenever you do orbitotomies, you can encounter fat. So this fat is easily compressible. You see there? So the mass is underneath. Do not biopsy the fat instead of the mass. This is a superior orbital mass with bone excavation. It lies close to the bone. You can see the dura is exposed. So here I went through an upper lid crease. So all superior masses now, I don't know, I go through the upper lid crease. Oh my God, time is there. So this was, the bone was exposed. You can see the bluish mass there. And this turned out to be a hematoma. This is again a huge mass in the superior orbit with bone excavation. Do you see the bone excavated out? And this I did through the conjunctiva. I realized later that it was a mistake, tagging the superior and the medial rectus. And the mass was very huge, and it reduced 2 years of my lifespan actually. It was so huge. And yeah, the conjunctiva is then sutured. This was turned out to be a schwannoma. I'm running out of time. You can either do an upper lid splitting incision for the previous case, where you can split the lid, enter directly into the periorbital space, or nowadays we do a lid crease incision only. This was a case done some years earlier. This turned out to be a hemangiopericytoma, also now coming under the term solitary fibrous tumor. You have to suture the lid back. That is a problem. Even in dermoids, you should be very careful. You have to remove the whole wall of the dermoid, otherwise it will recur. So in such cases, do not compromise on the incision and do a conjunctival approach. So lateral orbitotomy, I think, can I take 2 more minutes? Yeah. So lateral orbitotomy is now done through the lid crease, extending along the laugh line. This was a bone with mass with bone excavation, bone erosion. So here you can see that the lid crease incision is along the horizontal line, but the periorbita is incised along the vertical line to avoid injury to the facial nerve. So here the lid crease incision is made at the lateral canthus. You extend the incision along the laugh line, and the lateral rectus is tagged. The orbicularis with the skin is retracted, and now the incision becomes vertical. So that is a lateral orbital margin. the anterior part of the lateral orbital margin, and about 2 millimeters behind that you have to incise the lateral orbital margin, elevate the periosteum, and once you reach the lateral orbital margin, the incision becomes the lifting the periosteum becomes easier, and I think I'll fast forward it a little, and you can see that the mass was very hard, granular, and it turned out to be a tuberculosis of the lacrimal gland. The lines of tension should be sutured separately. I am using interrupted sutures for the laugh line and subcuticular sutures for the lid crease. So you can see the scar sitting very nicely in the lid crease. If you have bilateral lacrimal gland masses, you just need to biopsy. You can go through the transseptal route, where you need not cut away the bone, do not punch the bone. You can just make an incision in the septum, the lacrimal gland will prolapse out. So dermoids, never play with dermoids because you have to remove the whole thing. So I am marking the lid crease. The incision is not so long, just to mark the lid crease, and then small extension along the laugh line so that it's easier to remove. And then you have to remove the dermoids in toto, so otherwise patient will come to you later with a recurrence. And then I don't use a cryo for dermoids now, and then excise it. So we have tamed wild animals even, so why don't we, you can, orbitotomy is easy once you know how to approach it. Thank you.
Thank you so much, Dr. Annie, for the illustrious demonstration of various approaches to the orbit. Now I invite Dr. Akshay Nair. Dr. Akshay is NRK oculoplastic surgeon, I would rather say. He did his basic medical education from Mumbai, and later then did his fellowship from LV Prasad Eye Institute, and his further subspecialty fellowship from New York. Now currently he is practicing in Mumbai, and he is very famous over here. Once in a while he visits his hometown, no?
Supposed to be.
Yeah, okay. Thank you. Over to Akshay.
Thank you so much, Marian. So I'm going to talk about, when she gave me the topic of what is new in ptosis, there's actually nothing new in ptosis, but still there are, ptosis is a condition and a surgery that's constantly evolving. So I thought I'll present a little bit about what is old in ptosis, which we should not forget, as well as a little bit of what is new in ptosis. So this is an interesting thing that I keep finding that pops up on my YouTube feed about what is new in ptosis. And they talk about face yoga and exercises to correct ptosis and droopy eyes. And if you once in a while are feeling low and need a good laugh, I recommend that you watch these videos. They are hilarious. And for the record, face yoga doesn't help in improving ptosis. So when I'm talking about what is old in ptosis, I'm going to go past some important things that as oculoplastic surgeons and as ptosis surgeons, we shouldn't forget. So these are like 10 commandments which I have created with, these are my mistakes. These are things that I've learned from others' mistakes, trying new things, because at the end of the day, we have to keep evolving and learning and not take ourselves too seriously, because there are times where we will also make mistakes. Because ptosis is as much as an art, ptosis correction, as it is a science. So this is what's old in ptosis, but unfortunately things that we cannot afford to forget. So my rule number 1 is documentation. Every visit of any patient, not just ptosis, I always take photographs. The entire preoperative session includes pre-op photos, counseling, when I discuss surgical options, and again photographs on the day of the surgery as well. And I always recheck measurements. This also helps you to streamline your plan, confirm your plan on the day of the surgery. Because patients will sometimes come and tell you after ptosis surgery there is absolutely no difference before and after. And patients may not appreciate or understand the difference. Patients may lie, but photographs don't. So always document. So this is a patient who came, now this is coming to my second rule. Now this is a patient who's come, 22-year-old male, congenital ptosis. You can see the levator function is very, very minimal. And he's got a slight Marcus gun also. 618 right eye, 6.6 left eye. what surgery would you prefer? Any options that you offer this patient for a surgery? A levator resection or a sling? Sling. So I always look at the patient, and if you see the brow position, the patient is actually having no incentive to lift the brow. He's amblyopic in that eye. So unless you have a sling which statically lifts the eyelid, he's actually not going to use his eyebrow to lift the lid at all. So there is no frontalis action, and at the end of the day, tarsofrontalis sling is a surgery where we harness the power of the frontalis to lift the tarsus. So if there is no frontalis action, he's not going to lift his eyebrow. So this was a patient in whom I ended up doing a supramax levator resection, because we traditionally are taught to decide surgery on the basis of levator function and not actually the patient's physiology. So sometimes they really don't use their frontalis, and in those patients a sling may not really help. So be flexible and improvise, do what is needed and not what the book tells you to do. Now look at this patient here on this. You can see the frontalis overaction. You know he's trying to lift the eyebrow with his eyelid with his eyebrow. He's going to be a good candidate for a tarsofrontalis sling. Similarly, this is a candidate whose eyebrows in normal position when trying to open his eyes are not arching. The frontalis is not working. So in this patient, I would do a supramax levator resection, and that's exactly what we did, and we are able to get a good outcome. So rule number 2 is be flexible. Moving on, this is a patient, minimal Marcus gun as you can see, and this is a child who's got again mild ptosis but huge Marcus gun. So I always ask the patient, what is it that they want to be treated? Because each case of Marcus gun is different. Listen to the patient concern. Oftentimes, I always ask patients with Marcus gun, what is it that bothers you? Is it the drooping or the ptosis that bothers you, or is it the Marcus gun that bothers you? Because if you have a fixed plan in your head without listening to the patient, with a hammer in your hand, everything that you see is a nail, and you're going to be hitting it. So you have to come up with, address the patient's concerns individually. If it's only ptosis that bothers them, ignore the Marcus gun, just correct the ptosis. If it's the Marcus gun that bothers them, customize your surgery so that the Marcus gun is abolished, which means a levator excision and a sling. So answer their questions carefully and don't lecture them on ptosis surgery. They are not a fellow, and these are things that I've learned on my own. Patients don't want to know the technical details. They need to know what helps them. All right, so this is case number 4. A 2-year-old girl came accompanied by the father. Father said left eye droopy since birth. Investigations were done. We are planning left eye resection. On the day of the surgery, mother comes and tells father doesn't know anything. Both eyes are droopy. Then you don't operate only one eye. And imagine my fright when the patient came like this on the day of the surgery. So this is a case of myasthenia. Myasthenia does not have any restriction on age of presentation, eyelid of presentation, motility, ptosis. So going back to rule number 1, document. If I had not taken photographs, nobody would have believed. That child had a thymoma, which is why 10% of all myasthenics under the age of 40% have thymoma. So if you have a child or an adolescent who's suspected of myasthenia, always get a CT chest. The 73-year-old male had a recent history of head trauma and diplopia. 2030 was the vision, and this is his motility. It doesn't fit into any particular nerve palsy. So a neuro-ophthalmic colleague of mine did an MRI. MRI was normal and said he's had a trauma. This is partial traumatic third nerve palsy. That's like a new recipe of a dish he's made, because there's nothing like a partial traumatic third nerve palsy. All the patient needed was an eyes test, and the patient motility and ptosis had completely resolved. So as you can see, diplopia also went away. The history of trauma was just superfluous. So at the end of the day, rule number 4, eyes is nice. Every patient of ptosis who gives us even the slightest diurnal history variation, a diurnal variation history, get an eyes test done. Eyes test is where you keep the ice packs on both eyes for 2 minutes, and at the end of 2 minutes, a 2 millimeter difference in the height or improvement of ptosis is a positive eyes test. This is case number 6. So the 43-year-old female, history of domestic abuse. She was slapped by her partner. Their blurred vision and ptosis. MRI was done. It was called again third nerve palsy causing ptosis. Motility was fine, given oral steroids, and after a month was sent to me for ptosis surgery correction. This is Feb 2021. I did nothing, called her back in 3 months. April 2021, did nothing, call her back in 3 months. June 2021, she's nearly normal. So I think we also need to know, apart from which cases to operate, which cases absolutely not to operate. History of trauma, for 6 to 9 months, I would absolutely not even think of doing anything, especially if the patient has had a post-surgical, like a RD surgery or a cataract surgery or a posterior subtenons injection, which can cause some ptosis. Wait for 6 months. Don't revise, just reassure them. They'll come back to you and they'll be very happy. As oculoplastic surgeons, we should also again be flexible in our technique. Careful case selection of those patients with mild ptosis with a positive phenylephrine test. A posterior approach, conjunctiva Mueller's resection, is a very good option. So don't risk, especially for mild 1 to 2 millimeters ptosis, I prefer to go to the posterior approach. So always add that skill into your armamentarium. I know Dr. Hunavar is here and he's a fantastic proponent of Fasanella servat, but I'm not a big fan of it. I don't think sacrificing the tarsus for a fault of the levator is something that works well in my hand. So I prefer a conjunctiva Mueller's resection for these patients. So don't be afraid of the posterior approach and do learn it. It's a very simple surgery. I won't go through the surgical steps for sake of time. But at the same time, master your anterior approach, because at the end of the day, if a posterior approach surgery doesn't work, your anterior approach surgery is going to be the route to revise it. It is a familiar route for all of us, as Dr. Anis showed in those wonderful videos where you can go through the lid crease even for an orbitotomy. How do you do that? I think we all need to, at any stage in a career, understand our algorithm. Just like cataract surgeons have surgical induced astigmatism, not everyone's levator resection surgery is identical. We need to know how much of resection creates how much of lift in what, severe, mild, moderate ptosis. So we know exactly what is our surgical correction in our hands and approximately come to with our own algorithm. So we can revise, and if in this case we are able to predict our outcomes, even revise them in 1 week under topical anesthesia or even local anesthesia. The next thing, rule number 8, is pay attention to contour. Contour is extremely important because no two patients have the same contour of the eyelid. Now look at this patient, it arches flatly and then goes down medially, whereas the patient below has a nice curvilinear contour. So contour is key. Mark the lid crease, which is the highest point, and then mark the contour, because contour will guide the suture placement in ptosis surgery. And even now, doesn't matter how much experience you have, it's always good to mark the lid crease with a caliper for every case. I was visiting Dr. Bob Goldberg, who even now for every ptosis surgery marks the lid crease himself with a caliper. So I think if he does that at his level, all of us should do that, because it adds a little bit of more precision to our surgeries. And case number 10, can I have 1 minute? Okay. This is a case of a 44-year-old diabetic, ptosis in right eye for 4 years, went ahead, did ptosis surgery, and she comes back and tells me, you've made my right eye look good, but my left eye looks small. And of course, I looked silly because I did not pick up the Herring's phenomenon. She had to then undergo surgery in the other eye. And how do we know that she had ptosis, which I didn't check? Look at the eyebrow position. Her left eyebrow is elevated, which is masking the left eye ptosis. So there is brow elevation lifting both eyelids, but the ptosis is more severe in the right eye, so the right eye is unmasked. Now when the right eye operated goes up, the lid just drops because the lift innervation drive is no longer there. Herring's is a very, very real and very commonly seen phenomenon. We need to be a little more careful about it. Gentle negation of the frontalis is the way to assess Herring's while we do that. And again, remember rule number 1, without documentation, we would not be able to get the idea. Again, this is a photograph of a patient with ptosis in one eye. And now look what happens when she looks down. When she looks down, the ptotic eyelid goes up. So this is a case of an aberrant reinnervation following a third nerve palsy. And these are cases. Now imagine if we operate to lift that ptotic eyelid, she will have complete lag of thalamus with corneal exposure on blinking, because when she looks down, the lid retracts. So not all cases of ptosis must be operated. I'd happily refer him to my competitor, oculoplastic surgeon in Bombay, that this is not a thing that I want to take up. Whether it's poor ocular motility because of CPO, where you want to plan an undercorrection, or aberrant reinnervation, regeneration, poor bells, these are cases you don't want to touch. And finally, red flag patients, patients whose prior complaints is not ptosis, but previous visited surgeons who said that she did this, he did that. Patients who had multiple procedures are unsatisfied. They have an obsessive approach, who will ask for a mirror and keep demonstrating things which even as an oculoplastic surgeon we can't find on their face. Unrealistic expectations, excessive negotiation about the cost of surgery, repeated cancellation, rescheduling the surgical date, wanting eyelids like Deepika Padukone or Katrina Kaif for XYZ. These are all red flag patients who are best left alone and do not get operated by you, because they are not going to get satisfied by whatever procedure you do. So a quick recap on our pearls, which is documentation, be flexible, listen to the complaints patients before surgery, because otherwise you will definitely have to listen to them after surgery. Use the eyes test, be aware of which cases not to operate, pay attention to the eyelid contour, and Herring's phenomenon is something that. So is there anything new at all? Well, actually there is. We talk about frontalis flap as the latest thing in oculoplastic surgery. Well, in fact, it's not the latest thing. It's been there for almost 30 years. So frontalis flap is where we use the frontalis muscle to create a flap and lift the eyelid instead of the levator. My only piece of caution of advice for frontalis flap is that lag of thalamus post frontalis flap is lesser than that of sling, but it takes up to 4 to 5 weeks for the lag of thalamus to resolve. This is a patient at 1 month post-op, and you can see that the lag of thalamus is still there. In about 25 patients of frontalis flap I have done, 2 have developed exposure keratopathy and ulcers. So now I actually leave behind the frost sutures for at least 3 weeks after frontalis flap. But eventually they do very well. This is a patient with a frontalis flap. Amazing contour and amazing lid crease is seen, and patients are very happy. It appears more physiological. And finally, Upneek with his topical oxymetazoline eye drops, which are used, not available in India. A word of caution, I know it's the same as our nasal decongestant, but please don't put the nasal decongestant in the eye. It does not work that way. Thank you for your time, and thank you for the invitation, Dr. Marian.
Yeah. Thank you so much, Dr. Akshay, for that eye-opening presentation on ptosis. Next, I would like to invite Dr. Feroz. She is from Bangalore. She is going to speak about socket reconstruction. Yes, yes. Feroz is well known to all of us. She's even though she's not staying in Kerala, she is a Keralite. I would rather say NRK oculoplastic surgeon. She's a medical director of Horus Specialty Care at Bangalore. Over to Dr. Feroz, please.
Good morning to everyone. Of course, I'm more a Malayali than anything, based in Bangalore. And it's a pleasure to be back in Thrissur, because this is where I started my journey, my endless journey of being in medicine. And it's an honor and pleasure to be here with my own people. Thank you, Marian, for including me in this session. Can I have my slides on? Yeah. So I'll be talking regarding contracted socket, and a contracted socket is, something that most of the time that as ophthalmologists we ignore. We kind of tell the patient, okay, you can wait. But for a patient, it is so very important. And in my practice, I give it so much of a value, because you are valuing that individual, because that person with a contracted socket and a facial deformity undergoes a lot of social stigma. Be it personal, be it professional, even, interacting in a social a forum with, lifetime well-being is affected once when you have a contracted socket. So I find it so interesting to deal with these contracted socket and, get the things fixed for the patient. And that's exactly what I'm going to do today. Just discuss few cases. Are we on? That's fine. Okay. Good. Yeah, perfect. Yeah. Okay, so this is what we are going to do today, okay? Yeah. And these are my affiliations and my financial disclosure. So, as I said, it has a cosmetic blemish. It definitely has a psychological impact, social anxiety in these patients, and very low self-esteem. And when you deal with these patients, this is what you're improving. You're improving a changing a life of these patients. Now, this is a 36-year-old lady, history of vitrillage. All right. So you can see, fortunately, the left eye is perfect. She sees with that left eye. More affected is the right side. And she has an eyeball inside. Okay, she has a thicycle eyeball with grade, almost a grade 4 contraction over here. So my question would be, would you like to intervene? Anju? Yeah, yes, observe. You would try, right? I would definitely try, okay, yeah. So what I did in this case was, I released the ankyloblepharon, there was a symblepharon release, and then I did a large mucous membrane graft. This is all that I did, nothing great, all right? And she has an eyeball inside, which is blind. And mainly what is happening here is she has a volume, but it's mainly a surface loss, all right? So mucous membrane grafting and fornix formation sutures in this, yeah, so this is after the placement of the prosthesis. So a prosthesis could actually go inside with an expansion of the surface. Now this is grade 5 enucleated and radiated socket as a child for retinoblastoma. Well, the good advantage in this patient is he has kind of a very shallow and deep-seated socket. So he doesn't have volume, but it's a radiated socket. Giving a volume in this case, the only option that I have is a dermis fat graft, but well, dermis fat graft is very, very risky when it's vascularly compromised socket, all right? So what I did was, I didn't take too much of a risk. The only thing that I did was to place again a large mucous membrane graft and give him a prosthesis. He's extremely happy. All right, and the shrinkage of mucous membrane graft, if you place a large one, is quite unlikely. But if you keep a very, very small one, well, there is a chance of shrinkage as well. Now, so this is how the mucous membrane graft is taken. You can take from the buccal mucosa or the labial mucosa as large as possible. And as you can see here, you have to keep it very, very folded in the socket. So I do have a video here. How do I play this? Okay. Okay. I'll take you through very quickly. I'm sure most of you do a mucous membrane graft. So this is how we, this is basically traction sutures. This is a socket. I inject it and then, separate the conjunctiva from the subconjunctival fibrosis. So this is the center. I have actually marked the fornices, the lower and the upper fornices, from the lateral to the medial canthus. And before putting the graft, what I do is I actually fix the fornix. The fornix is fixed so that I exactly know what is the size of the graft that is required. This is the graft from the lip, a large graft, okay? An amniotic membrane graft is placed so that healing is good. And this is how you actually harvest the graft. And this is how big the graft is actually, not just fitting, but it has to be really, really folded. So once when you keep the conformer, it really expands and it gives a nice surface. And finally, after the placement of the graft and the conformer in position in the center, then you actually tie the fornix formation sutures, and this is how it goes. All right, now this is a contracted socket patient with granuloma, a long history, 50-year-old gentleman, frequent bleeding, road traffic accident, enucleation without implant, secondary implant extrusion, repeat implant placement twice elsewhere, and then a mucous membrane in the lower fornix. Okay, so when he presented to me, he had this bleeding happening, and this is how his fornix is. Okay, now what do? I really don't want to touch too much into the socket because it has been operated 3 times, 4 times. Why do I even want to go inside and create more scarring, right? The only thing that I did was to form the fornix for him and a lateral canthoplasty. That's it. All right, and of course, I've been treating the granuloma with injection of triamcinolone acetonide. That's all that I did. Very minimal, but the patient is happy. Now, contracted socket with customized oculoprosthesis. He has a contracted socket, no implant inside, but the patient is okay. The prosthesis is beautiful. The color matching is so beautiful, all right? But then it doesn't look that great, all right? He did have a nice surface. So what I did was to give him a secondary implant. And yes, so the placement of secondary implant also depends upon how good the ocular surface is. If the ocular surface is good, you know, you can always go for a secondary implant. But then otherwise you have to think of other things which we will discuss here. So what is contracted socket? This is just for the PGs where reasonably sized prosthesis cannot be placed or retained. So we have different classification. I'm not going into the detail. It's just to give you a highlight here. Grade 0, grade 1 where 1 fornix is involved, 2 fornix involved, grade 2, grade 3 when all the fornix is upper and lower fornix is involved. Now this is where the palpebral fissure has completely closed. Grade 5 is a refractory socket, okay? Now another classification is congenital and acquired. You can have bony contraction, soft tissue contraction and both contraction. Now going on to management, if there is congenital microphthalmia or anophthalmia, you can give serial conformers as in this case, and finally a customized oculoprosthesis. But now in my practice, I actually use serial customized oculoprosthesis right from the beginning. And this is how early we start. At 2 months, this child started receiving customized oculoprosthesis. At 3 years, I actually enucleated, gave him an implant, and this is how he looks like. This child, how early? At 27 days, this baby came to me. Immediately, I started. This is just before her first birthday at 11 months, and this is like last month I saw her at 4 years. Now, this is a patient who have presented when he was an adult. He was 24 years when he came to me. A little bit difficult, but still I don't give up. I usually don't give up in my life, all right? So what I did was dermis fat graft in him, okay? Dermis fat graft, good prosthesis, and well, he was so happy he got married, and he has a beautiful wife. All right, yeah, so basically the principle is look for surface loss, look for volume loss, and both surface and volume loss. I'm going to share my secret to you, okay? So this is what works for me. This is exactly what I do. I look for a shallow fornix, how the fornix is, then I evaluate the surface loss and the volume loss. I'm not going to explain the whole thing. You can take a picture and we can discuss later. And depending upon that, I plan my management. If the surface loss is really bad, but there is volume, it's just the MMG or AMG that you have to think of. Volume and surface, then dermis fat graft. And well, we do have other options like exenteration prosthesis. Now, fornix formation suture, never compromise on this. Just don't think that you'll put a good AMG or DFG or MMG and then put a confirm and it's going to work. It's not going to work, all right? You have to fix the fornix. You have to go fix the fornix, taking it through the periosteum so that it's permanently staying there. And that's so very important. Please don't compromise on that. All right, and well, this is how it looks like. And this is a patient. He was an army officer from Yemen, and he had an injury with bullet in his eye. Okay, eyeball is shrunken, lateral canthus is gone. So what I did was dermis fat graft, lateral canthoplasty, and this is how he went back. All right, this patient had evisceration and he had integrated implant. You know, we used to have this where motility was improved earlier. With a pegged integrated implant. It has complications of granuloma. We no more do it. And he had severe complications. The implant was taken out, it extruded, and this was how sad the patient was. He's like, I have to suicide. I cannot live, all right? Well, so what I did was treated his socket, of course, severe granuloma for almost 2 months. And then that is with the conformer up there, and this is the prosthesis. Well, not super great, but well, he was happy about it, and I was also satisfied. So this is what we do in dermis fat graft. I usually take it from the buttocks, and this was my thesis when I was a postgraduate student. So my colleagues and my teachers used to call me the buttocks doctor, because all the patient with stitch in their buttocks, it's my patient, all right? 32 cases, all right? So I have been loving this surgery right from then, and this is how exactly dermis fat graft looks like. So going back, you have a surface which is almost 20 millimeters, and then you have a volume. What else do you want? You're getting the volume and you're getting the surface, all right? Yeah, so let me see whether it quickly Okay, so this is the gluteal region, my favorite region. I work on my glutes also. So this is where I take it from. Okay, yeah, I'm just going to go through. So this is how it goes. So dermis fat graft, initially it looks like white and then it conjunctivalizes. So a conjunctiva is growing over it, a new conjunctiva, a new surface is growing over it. And this is how it looks like. Okay. So this is again a road traffic accident, globe rupture, facial-maxillary fracture, enucleation plus implant elsewhere, and he has a dacryocystitis, secondary saldo, dacryocystitis. So what I did was dacryocystectomy and medial canthoplasty in step 1, and then what I did was MMG and FFS in the stage 2. And this is how overall he looks like. So there is a combination of everything that happens in these patients. Grade 5, enucleated, radiated with multiple socket surgeries. She was referred to me, to my ocularis for exenteration prosthesis. All right, so well, as I told you, I don't give up much in life. So I thought, well, giving her an exenteration prosthesis, she's so young, she's going to have a long life to live, right? So what I did was I tried. I again gave a large mucous membrane graft, and this is how she looks like. Not an exenteration prosthesis, but well, there is definitely, this patient was surgery phobic because the child has undergone multiple surgeries, and the father is like, no, we don't want any more surgeries, but give us some other solution. And then she received an exenteration prosthesis. So well, I'm done. This is how the summary is, what works in grade 1, grade 2, grade 3, grade 4, and grade 5. In short, so it's so very important to have a very meticulous assessment to decide what was the cause and what would be the effect if you intervene and if you don't intervene. And taking a wise decision in socket is very, very important. Thank you so very much, and this is where I all started. I'm so happy to be here, to be in Thrissur. Thank you for having me here. Thanks a lot.
Thank you so much for that lucid presentation on socket. Now we invite Dr. Santosh Honavar, and we are so blessed to have Dr. Honavar sir is with us today. He doesn't require any introduction. He's the Honorary General Secretary of All India Ophthalmological Society, and he's the mentor of all the mentors. Over to you, sir.
Thank you, Marian, for the kind invitation, and I appreciate that you sacrificed your talk, and I'll try to finish it early so that you can also squeeze in your talk. I'll be speaking very quickly on oncological principles which can optimize outcome in oculoplastic surgery and restrict myself to orbital surgery so that Marian can get some time to talk. Orbit is a Pandora's box full of evil. That's because 50% of orbital tumors are malignant, and thereby lies the implication on life and eye salvage as such. So that is the reason why you should actually combine your oculoplastic surgical skills with oncological principles when you manage orbital tumors. That will optimize outcome. Now, what are the oncological principles? I'll give this to you right away. Oncological principles in orbital tumors are irrespective of what the tumor could be, benign or malignant, based on your clinico-radiological evaluation. If it is well circumscribed, then you must completely excise. There is no role for an incisional biopsy in a well circumscribed tumor that is not affecting critical structures in the orbit. I'm not talking about optic nerve tumors here that are well circumscribed, but I'm talking about tumors which are well circumscribed, which are not affecting the critical structures in the orbit. Then when you want to excise, you go to minimal interventional techniques. Minimal dissection of planes, minimal cutting of bone. If at all it's required, we don't cut the bone anymore. And whenever you want to do incisional biopsy, it should be multi-level or at least past the epicenter. If this is a tumor, you have to go beyond the epicenter of the tumor to take an incisional biopsy, not just the superficial part. Whenever it is indicated, you have to get an intraoperative diagnosis so that you know exactly what the tumor is. Based on that, you can take some intraoperative measures, whether to go ahead and debulk it, irrespective of what happens to the ocular motility or not. If it's a highly malignant tumor that cannot be dealt with by any other modality except surgery, you have to do surgery. And that is the reason why intraoperative diagnosis becomes very crucial in certain clinical situations. Then finally, HP-guided adjuvant treatment. You have done the surgery, pathology tells you some information. Based on that, you have to go ahead and treat the patient. Unless you do that, you're treatment will be incomplete. In certain situations, we use surgery, radiation, and chemotherapy in a specific combination. Surgical approaches are many, but we currently believe that less is more, in the sense that we use transconjunctival orbital approach to a majority of tumors. At least about 70% of the orbit can be accessed by transconjunctival approach, except the superior part where LPS comes in the way. So that is what we do. I'll skip the video, but basically a patient who has an intraconal tumor like this can be accessed by inferior transformational approach. Left eye, you can't even see a scar after 3 weeks after surgery. All that we did was a small lateral canthotomy and inferior cantholysis, and the tumor was accessed by the inferior transformational approach. Now about incisional biopsy, we all know the indications, but mainly any tumor that is ill-defined or is involving a critical structure where you can't clinico-radiologically pinpoint a diagnosis deserves an incisional biopsy. So suspected malignant tumors, poorly localized and infiltrative, associated with critical structures, if you want to excise that, those critical structures will be damaged, and you don't want to do that unless you know what it is. Intraoperative diagnosis is required. But whenever you do it, it has to be a direct approach. I will show you this pathetic example, sorry to use that word, of a lacrimal gland adenoid cystic carcinoma where the surgeon has done a lit crease approach and has just done an incisional biopsy. The tumor has promptly come back after radiation and chemotherapy that they did. And where has the tumor come back? Tumor has come back here, tumor has come back here, all under the skin flap. Why? Because an incisional biopsy will seed the tumor in multiple planes. And the radiation oncologist would not know what all planes have you seeded. He would give radiation in this area. And the same patient has also undergone a lateral orbitotomy bone cut, which was not really required in adenoid cystic carcinoma. And what has happened? Tumor recurrence is in the temporal fossa as well. So you should never attempt lit crease incision in a suspected adenoid cystic carcinoma, because you're going to seed the tumor all along the suborbicularis plane. You have to do a direct approach right over the lacrimal gland with a direct perpendicular incision and a transeptal or transarcus or transperiosteal incisional biopsy. The second concept is about 8 to 20% of orbital biopsies result in non-specific or misleading diagnosis. That's either because of a bad sample or because of non-uniform tissue pathology. I will show you an example of a child with rhabdomyosarcoma. When I do a biopsy, I do a superficial, mid-zonal, and pass the epicenter and send all this to my pathologist. As part of the study, we did this. But generally, what is important is that you should go past the epicenter. You know the epicenter on radiology anyway, so you should go past the middle of the tumor. That is what is important in incisional biopsy. Now let me show what the superficial biopsy showed. This clearly shows that there is inflammation and sclerosis. So if I were to stick to superficial biopsy in this child, the diagnosis would be non-specific inflammation. Based on that, somebody would have treated this patient on oral steroids, which would have anyway delayed the diagnosis, appropriate diagnosis. Only the deep biopsy revealed embryonal rhabdomyosarcoma in this patient, and of course the child responded. So you have to go past the epicenter of the tumor. That is when you do incisional biopsy. Then multi-level biopsy is important. Right. Then the intraoperative diagnosis. A child like this, where there is a quiet tumor lying there for about 9 months, your clinical diagnosis would be eosinophilic granuloma. But it could be anything. But it has destroyed the roof of the orbit. The dura is involved. So you can't be very exploratory or aggressive in this situation. So what I would do is direct approach, biopsy right from the center of the lesion, without disturbing the dura or the superior rectus LPS complex. You get the diagnosis that it is eosinophilic granuloma. All that you need to do is inject triamcinolone within the lesion intraoperatively, and over a period of 3 and 6 months, the bone completely remodels without the need for a major surgery. So intraoperative diagnosis is recommended whenever you have a doubt about the diagnosis and when you don't know what is the next step to take. Pathologist will tell you what is the diagnosis within 10-15 minutes, and thereupon you can take your correct approach. And what if you have excised the tumor completely and know that you have excised the tumor completely? This patient had a SFT involving the infraorbital nerve. I have taken out even the nerve. But beyond that, it was an aggressive tumor. So what do you do in an aggressive tumor of this sort? You have to go ahead and give stereotactic radiation. Like orbital lymphoma, you have done an incisional biopsy. When it is shown that it is mantle cell lymphoma, you have to go ahead and give rituximab. Finally, about multimodal treatment. There are situations where orbital excenteration may be your primary choice of management, but that results in very high mortality. So in such situations, you may want to conserve the eye, you may not want to conserve the eye, but you have to employ surgery, radiation, and chemotherapy, all the modalities. Here the steps are that we have to do biopsy to confirm the diagnosis, then provide adjuvant chemotherapy, biologicals if required, and stratify the risk, and finally treat the patient. This has been very well used in retinoblastoma. You can see all this with good success. Cosmesis is the bonus in such situations. In rhabdomyosarcoma, where you want to preserve the extraocular muscle, inferior rectus has been preserved here by creating a wedge which has been left out and rest of the tumor has been removed, and rest of the treatment obviously is with multimodal treatment. Even when you want to do orbital excenteration, you can reduce the size of the tumor and make this surgery safe for the patient. And in adenoid cystic carcinoma, the role of multimodal treatment has been established, where you begin with neoadjuvant chemotherapy, shrink the tumor down, and then do just the en bloc excision without bothering to do orbitectomy, which we used to do earlier. You can see bone completely remodeled over a matter of 6 to 9 months following this treatment. A child, again, completely remodeled bone. For recurrent adenoid cystic carcinomas, we can devise afterloaded interstitial brachytherapy to the bed of the tumor by using iridium-192 sources with much better outcome. So in conclusion, I would say that oncological principles actually help salvage a lot of life, eye, and vision, of course, vision in orbital tumors. Thank you so much.
Thank you so much, sir. Any doubts from anybody before I start my talk? If any doubts that can be asked now. No, afterwards we'll not get time. So I'm just speaking about the management of thyroid eye disease. It's a case-based approach. So we know that first we have to categorize the disease: active, inactive, mild, moderate, or severe. Disease activity and severe. What is disease activity and what is disease severity? So active disease will have inflammatory features and inactive will be having fibrotic features. So this is a clinical activity score based on pain, redness, swelling, and impaired function. So this, from the clinical features itself, you know this is an active disease. So International Thyroid Eye Disease Society has come up with a patient evaluation form which can be used in our clinics, and it is very useful actually. So in this case, it looks inactive, but the patient is having increasing proptosis as well as constant diplopia. So he also belongs to an active disease, but it is a phenotypic variant is different. So he needs treatment. So coming to severity, it is a physical sequelae of activity. It can have cause functional and cosmetic defect. So severity has been divided into sight-threatening, moderate to severe, and mild TOD. The main thing is you have to assess the poor prognostic factors, which I am doing in nowadays. We have to check for TSS receptor antibody, history of radioactive iodine therapy, male sex, age more than 60 years, diabetes, smoker, history of other autoimmune diseases, history of obstructive sleep apnea. This is very, very important to assess the prognosis. So first case, 50 years, female, redness, presented with redness, irritation, edema more in the morning. So this is a clinical picture. Obviously, you can see some sort of fullness, but otherwise eye looks quiet. Now what is it? So I suspected two things. Either it can be related to thyroid or can be related to sinusitis. But however, her thyroid is normal. So I did a CT scan which shows very subtle thickening of inferior rectus and medial rectus and fat predominating. Since it was suggestive of euthyroid ophthalmopathy, I took an endocrine consult and she underwent a thyroid scan, showed a cold nodule and advised thyroidectomy. So this is the way patients are presenting to us. Even though there is no clear-cut signs of disease activity, mild thyroid eye disease presents with this dry eye-like symptoms. So but beware. So we are seeing two patients. One is both are axial proptosis. But always check thyroid. If the thyroid is normal, you have to get a scan done before you put it as euthyroid ophthalmopathy. Otherwise, you can miss things like this. It's a case of intracorneal mass schwannoma. First case, it was a thyroid eye disease. So that's the take-home message. If you see a unilateral proptosis, we know thyroid is the most common cause. But if thyroid is normal, get an imaging done before you label it as euthyroid. Orbital imaging when vision-threatening disease, moderate to severe disease, euthyroid ophthalmopathy before decompression. CT scan is the image of choice. So coming to the second case, so this is, obviously this is an active disease, both eyes, right eye vision is PL, left eye CF 2 meters. He's a known case of hypertension, hyperthyroid, TRAP positive, glaucoma, diabetes, already treated with IVMB. See, she has got many of the risk factors. You should be very careful in treating this patient. Lag of thalmos, corneal ulcer, fundus, you can see disc edema. Scan was suggestive of everything. So what are the concerns in this patient? Thyroid, poor prognostic factors, bilateral compression, status post medial prednisolone, lag of thalmos, corneal ulcer, glaucoma, diabetes, hypertension. She has got all the problems in the eye. So we took a cornea opinion, corneal scraping done, fungal corneal ulcer. So the immediate aim is to protect the cornea before jump into decompression. So I did a regular tarsography will not help. So I did a canthotomy, cantholysis, then I levator recession, and then did a tarsography just to protect the cornea. So post tarsography, she has improved, the cornea has improved, then he underwent endoscopic decompression, vision also has improved. This is her 2 weeks post-op, but after tapering the steroids, vision again dropped, then she underwent radiation. After radiation, she developed cataract, she underwent phaco with cataract. Eventually, she did well with squint remaining. She has got 6.9 and 6 in the right eye and 6.18 and 8. Fundus also has improved. See the improvement in disc edema. So in each case, you need a graded approach. So 2 minutes. So this is another case, 50 years, IVMB 3 grams, proptosis, and again referred because of high risk for decompression. He's a known case of chronic kidney disease on dialysis. So GA is always risky. This is his clinical picture. MRI, again we managed in the same manner, tarsography with the blepharotomy. He has improved once the blepharotomy was done and tarsography was done, and he did well without decompression. So there are various steroid regimens, oral steroids 1 milligram per kilogram per day, taper over 3 weeks, total period 6 months, 24 weeks, that's 6 months. Then pulse therapy can be given, Kahali's regime, that is 500 milligram weekly for 6 weeks, then 250 weekly for 6 weeks. Steroid sparing therapies, then radiation can be given 10 fractions per 2 weeks. But here it is given in steroid responsive compressive optic neuropathy or an alternative acute phase decompression of prolonged steroids. Coming to case 4, he's a 55 years inactive TRO after all the treatment. So she underwent decompression, then followed by squint correction, and then retraction correction. Lid retraction can be corrected in many ways, non-surgical and surgical. Non-surgical, filler, Botox, triamcinolone. I'm not going to the details. Levator recession is the surgery. Triamcinolone transconjunctivally can be given. It is a very good, it improves retraction. So to conclude, TAD is a highly stigmatizing disease. Control the inflammation remains the important. And case-based approach is very, very important. Multidisciplinary approach will give you a very good result. And we have run a thyroid eye disease clinic with a group of endocrinologists, rheumatologists, ophthalmologists, radiation oncologists, and ENT surgeons. Thank you. All the speakers are here only. I thank all the speakers. I hope we are able to finish on time. We'll take any. Yeah. And thank all the audience also for